10 out of 10 bilateral arm and upper back pain, requesting a lot of PCA with Benadryl for pain. So any thoughts, any plans, any questions you would definitely ask?
Right now, chest pain.
Chest pain, okay, yep.
Shortness of breath.
Shortness of breath. Okay, so what are you guys getting at?
Acute chest.
Acute chest, okay. Anything else?
That just happened before.
Yep.
What does he normally take if he's had symptoms like this in the past?
Yeah. So again, what are you sort of getting at? Like, has this happened before, just to know if it's similar to other episodes, or is it to gauge the severity of the sickle cell disease, or? And then for the pain, just to know what.
Like to know like who treats him, like how he normally gets treated, and like what works for him.
Yeah. Anything else? And I guess another question would be, sort of when you see a patient with sickle cell disease, are you sort of thinking, oh, this is a complex admission, this is not, this is like, well, I'll have to do a lot of thinking, this patient is sick, is not sick? What's your general impression when you get a patient like this?
It's not usually that complex. Most of the things that they come with are related in a way or another to an acute, episode, which usually can resolve with the typical management.
Okay.
But sometimes it can get messy.
Okay. So we'd say,
Especially if it is like a 36 years old. Usually, if it is sickle cell disease, they would have a complex backstory.
okay, yeah. So maybe someone that's had like a long path within the healthcare system, and so maybe not like, overwhelmingly complex, but with the ability to become quite acutely sick. Is that sort of the general impression? Okay, great. So I'm just gonna go through a little bit of the
Like an important thing to consider in these patients, because a lot of times these patients come in asking for pain medications, and like a lot of times when patients come in for other causes just asking for pain medications, we sort of chalk it up to substance use, but these people are actually in a lot of pain, and need to be treated accordingly, despite whatever substance use they might also have. So sort of considering the pros and cons of that.
Yeah, I sort of agree, right? I definitely agree. I think we run into the problem, right, where I feel like a lot of the time the solution to what we think is a potential substance use disorder is to just not give adequate pain control, but we don't actually then follow through and do things like counseling, referral to programs in the same way that we treat a traditional substance use disorder. So we sort of do both, right? We not only undertreat their pain, but then also do not go through with our sort of normal, process that we would do for someone else that we think has a substance use disorder. So we somehow manage to undertreat stroke or critical illness, right? So this is sort of what you were touching on, right? It might not just be the pain, right? It might mean that there's impending, other critical illness. And that there was one study that showed about 80% of patients attempt to minimize the use of the healthcare system because of the stigma they receive around pain medication. But it's sort of, the problem is that these things are sort of overlapping, right? Because as patients have more frequent ED visits and hospitalizations, they're at higher risk for death, right? But they receive some more of what they feel is stigmatized behavior, and then they want to avoid the healthcare system, even though this is probably predicting that their complications are getting more complex and severe. And then there's, again, sort of similarly, there's higher levels of perceived discrimination associated with worse pain, right? So all of these overlapping things are leading to worse outcomes. And then this also did make me think, right? A high tolerance and medical knowledge is seen as drug seeking, right?